Good morning. I'd like to welcome you to this joint webinar between the University of Manchester and the Chinese University of Hong Kong. We've got a very packed hour today. We've got 4 wonderful speakers. So I will stop sharing my screen. My name's Lucy Frith from the Centre of Social Ethics and Policy at Manchester University. And I will turn over to our first speaker, who is Professor Soren Holm, who is from Manchester. So Soren, please. So I think you're on mute, Soren.
Okay, can you see my screen? Okay.
Yes.
Okay, so I will briefly talk about how we should understand the early English COVID-19 response. Now, what were the policy options for England in early 2020? Well, if you think of it sort of purely as a listing of options, there would be an option of trying to go for zero COVID, so full suppression. Essentially, sort of every time there was a local outbreak, try to whack that mole and fully suppress community spread of COVID. Then there is an option of flattening the curve, simply saying, well, we can't suppress COVID fully, but we can control it in the sense that we can keep community transmission to a reasonable amount, which will allow, for instance, the National Health Service still to function. And then you could go for a herd immunity strategy, which would essentially be the do-nothing strategy and just let COVID sort of go through the community until enough people had it and you would have achieved herd immunity. Now, it's important to remember that the realization of the severity of the COVID problem was only gradual. It only sort of really entered policymaking circles in January of 2020, and at that time wasn't conceived as a very severe problem, but then it became more and more recognized that it was a problem, and eventually England entered a lockdown with the aim of flattening the curve on the 22nd of March 2020. Now, what was known at that point during the policy making? Well, it's important to remember that a lot of what we know now was not known then. We knew some basic epidemiological facts. There was an estimated very high R number, so the number for how many people a COVID-19 sufferer will spread the disease to is estimated in the range of 2 to 5. We knew that there was a steep age gradient in morbidity and mortality, and it became apparent as time went on that there had already been multiple introductions and was ongoing community transmission in England. Later in the policymaking cycle, there were some countries in Europe who had this earlier than the UK, Italy, and Spain. So some, well, they had very bad COVID experiences, and that also influenced UK decision-making. Now, this is from a paper in Science, where people have looked back and traced using genetic methods the transmission, the individual transmission lineages which can be identified. Now, this is all retrospective, but as you can see, sort of this is where the lockdown comes in, and at that point, there are already a very, very large number of transmission lineages, and this is not for England, but for the UK. You can also see that most of this comes sort of from the beginning of February, where it starts to come in from Italy. Then later it comes in from Spain. And you can see here that sort of travel continues almost at the same level until the lockdown is introduced. So essentially, if you wanted to pursue a zero COVID full suppression strategy, you would probably have to have started pursuing that strategy sometime in early February to have any chance of it working in the UK. Now, all of this is retrospective, but this is also what the modeling showed, that sort of in March, there were already widespread community transmission in the UK. Now, what was not known at the time of political decision-making was the mix between different modes of transmission, exactly how SARS-CoV-2 was transmitted, the effectiveness of different social distancing interventions, the effectiveness of hygiene interventions and mask wearing, and of course, very importantly, at the point of decision making, no one knew how long it would take to develop effective treatments and vaccines for COVID-19. So there was a huge degree of uncertainty. So when we get towards March 2020, does England have a choice of overall approach? Probably not. At the point in time during March when the issue finally reaches the top of the political agenda and it becomes clear that some policy has to be introduced, there is probably no choice of what that policy should be. Full suppression is no longer an option because of already widespread community transmission. Sort of the whole lawn is full of molehills. You cannot whack the mole. It's simply impossible to get down to zero COVID transmission in the UK. Herd immunity, although it was discussed, was actually never really an option because of the very high likelihood that it would lead to a collapse of National Health Service provision and very large number of deaths. So the only possible option was flattening the curve through social distancing. So the real policy question in the UK was not what to do, because there was only one option, but exactly how to do it. Now, when the lockdown was first introduced in the UK, the first lockdown we had, there were huge uncertainties about how to do it, exactly what would work. So we might want to criticize exactly how it was done, but that would be using the retrospectoscope at the point where policymakers had to make these decisions. They were doing it in a situation of huge uncertainty. Now, if we want to criticize lockdown measures, it would probably have to be a criticism of the second and the third lockdown, because at that point, much more was known than it was in March 2020. And if anyone wants to study the science paper, this is the reference. Thank you.
Thank you very much for that, Soren, and that was extremely interesting. So we're now going to have Roger Chung, who is going to speak to us about health inequalities in Hong Kong. And Roger is from the Centre for Bioethics, the Institute for Health Equity, and is an assistant professor in the JC School of Public Health at the Chinese University of Hong Kong. So thank you, Roger.
Thank you very much. Can you see the screen?
Yeah.
Is that okay? All right. So let me begin. So thank you very much, Lucy, for the very great introduction. So I'm a social epidemiologist. So today I'm going to take an epidemiological kind of approach to look at what had happened in Hong Kong, especially during the relatively low incidence period. So this is kind of, I feel like this is kind of like a counterpart to Professor Holmes' presentation of the UK situation. But nevertheless, I will have this ethical underpinning when I'm talking about the COVID situation of Hong Kong. So we all know that it is still happening, you know, resulting in more than almost 530 million cases and 6.29 million deaths worldwide as of the end of last month. So if we zoom into Hong Kong, this is what it looks like. Okay, it looks kind of like there is only one wave, right? But in Hong Kong, we call that the fifth wave. Why? Well, because when you zoom into this part, in the earlier part, well, there are actually little bumps. So, you know, using this approach, sometimes we call it the zero COVID approach or the full suppression approach, then, you know, if you go back to this slide over here, this epidemic curve, it almost feels like there is nothing over here, no waves, right? But when we zoom in, there's actually some little bumps, and that is really the situation of COVID-19 in the earlier days of Hong Kong, especially in 2020. Now we actually know the impact of COVID-19 can be categorized in twofold. One is the direct impact, one is the indirect impact. The direct impact would be, you know, the infection by COVID-19 of yourself or someone close to you, you know, your relatives or your family members. That would be a direct impact. But also there's indirect impact, right? So it's not just the infection, not just the infected by COVID-19 that matters, but also the affected by COVID-19 that matters. So here's the question that we were asking. Are there really no social inequalities in health related to COVID-19 in these regions, meaning in regions with lower incidence rate of COVID-19 during the time of fewer confirmed cases, like in Hong Kong? Are there really no social inequalities, right? So let's kind of look at Hong Kong. Okay, so Hong Kong geographically, it's in the south side of China. It has close proximity to Wuhan compared to the rest of the world, obviously. It has relatively low incidence in earlier days because we have stringent containment measures that impacted on probably the whole population and also economic activity. We're going to talk a little bit about that in a bit. And it also has high wealth inequality. The Gini index is very high in Hong Kong. It's 0.54 around. So again, when we look at this epi curve, okay, so this is the early days in 2020, okay, from March to April, and then from April to June. what we notice is that the so-called this wave over here in March was actually clustered among the people of higher SES. So why? Well, it's because a lot of people were actually coming back home from their spring break. They are people who, they're students. A lot of them were actually students on spring break. So then you can imagine those are the people, the children of families of higher socioeconomic status, right? They can afford to send their kids to study abroad, right? So that's this wave over here. And then afterwards, from mid-April to June, the end of June, we have a relatively stable period of time until then we hit another wave during summer. So let's look at some of these measures in Hong Kong. What did they do? Okay, January 23rd, that's very early, right? They closed all the schools from Lunar New Year holiday onwards to May 27th. 2 days later, they declared the outbreak an emergency by the government. They closed all theme parks. February 3rd, border control of inbound travelers from mainland China. And then on March 25th, border closure to all inbound travelers from overseas, and quarantine of 14 days for all returning residents of Hong Kong was also implemented. Then 2 days later, they banned all the indoor and outdoor public gatherings of more than 4 people. Restaurants operating half capacities and tables being set 1.5 meters apart. Then on April 1st, 2020, they also closed all the entertainment venues for 14 days. And then 2 days later, they then closed all the pubs and the bars for 14 days. Then by May 5th, social gatherings were lifted from 4 to 8, and then they reopened some of the businesses like the beauty salons and gyms. So this is just a picture of what kind of stringent containment measures they try to implement during the earlier days. So with that as the backdrop, this is the paper that I would like to, I'm alluding to, which is published in the Journal of Epidemiology and Community Health, where we are trying to answer this question. Thus, did COVID-19 related health inequality exist in a city where disease incidence is relatively low? We did a telephone survey, right? So this is the study period. We're studying during the period when the incidence is really, really low in Hong Kong. So the expected social gradient and health impact did not seem to exist in Hong Kong when we focus on COVID-19 specific incidents in the initial wave of outbreak. Nonetheless, we hypothesized that the outbreak could have exerted wider impact on social determinants of health. That in turn lead to health inequalities more generally. So the aim of this paper is to examine whether COVID-19 could contribute to any inequalities in socioeconomic conditions and health in Hong Kong, where, again, the incidence is low. So what we found is that being deprived, if you're poor, right, if you're deprived, you're more likely to have negative COVID-19 related issues, such as having low reserve of face masks in the household in the earlier days of the pandemic. You have more worry of the pandemic, and you also have a higher risk of job loss or instability. We also did a mediation analysis, and we found that being deprived, being poor, was negatively associated with physical health and mental health, and being worried about COVID-19 and the job loss or instability, the economic side of it, were also negatively associated with the physical and mental health. And being deprived had a significant indirect effect on mental health, with being worried about the pandemic and job loss and stability as the mediating variables, right? So the worry and the job loss really mediated this association. So here's a summary of our findings. The deprived fare worse in every aspect of life than their non-deprived counterparts after the outbreak. Could be work-related. They tend to more likely to lose their job. They could be related to materialistic concerns of personal protective equipment and also related hygiene practice, and also negative COVID-related issues after adjustment, even after adjustment for confounders. So these results were actually quite alarming because the deprived individuals had already been more prone to having worse demographic and socioeconomic characteristics even before the outbreak. You know, it's pre-existing, it's underlying, right? And the outbreak seems to expose these social inequalities more. So part of the health impact was contributed via general worry about the disease and the changes in terms of economic activity that happened after the emergence of the COVID-19. So the implication number one is that part of the observed health inequalities can be attributed to changes in social conditions as a result of the pandemic, even if the incident number is low. Number two, the mechanisms that contributed to producing such inequalities were related to the bigger concerns of the impact of the disease on one's livelihood and economic activity, and not necessarily the materialistic concern over adequacy of face masks and hand sanitizers per se. Which
2 minutes.
actually,
2 minutes,
sure.
Roger.
Okay, which drew much of the media attention, right? Why did I emphasize this point? Because if you're watching the television, you see that most of the news were about the incidents, were about protecting yourself, but much less on people's livelihood and economic activity. Now they're talking about it, right? Because it has been so devastating. So we did another more in-depth study with the scientific reports on another period of time. We found the same thing. Basically, worry about economic activities and personal savings matter to mental health and well-being, but not really worry about being infected in the later part of the 2020, and even not about PPE anymore, right? So as you go along, right, by September, by fall of 2020, people were not even worried about being infected or, the personal protective equipment anymore. They're much more worried about economic activities and personal savings, and those are related to the mental health issue. Here's my final conclusion. So focusing alone on the incident cases as the outcome of concern to address health inequalities is like a story half told, because it's left out important aspects of life that contribute significantly to our health. So economic worries being affected by COVID-19 matter much more to mental health than public health worries, i.e. infected by COVID-19. So social determinants of health cannot be overlooked in devising and designing any public health related strategies. And this is my last slide. So it is pertinent to consider public health ethics in the discussion of COVID-19 prevention and intervention strategies, which could also damage people's health, as we can see. So we need to balance it, right? We need to kind of think about what are the justificatory conditions for this utilitarian considerations of health protection to override other non-utilitarian ones like liberty, confidentiality, privacy, justice, equity. And as proposed in another paper that I wrote with my colleagues in the American Journal of Bioethics, where I list out 5 of them. So they are effectiveness, proportionality, necessity, least infringement, and public justification. So with that, I conclude my presentation today. Thank you very much.
Thank you very much. That was fascinating, really interesting to get that perspective. So now we have Professor Han, who is an emeritus professor in the Department of Philosophy at the Chinese University of Hong Kong, and will also be a visiting fellow at the Safra Center for Ethics, Harvard University, later on this year. So If you'd like to share your screen.
Sure. Is this okay? Thank you, Lucy, for organizing this webinar. So let me see, slideshow, play from the start. Okay, thank you. So my topic today is the relevance of moral theory to pandemic policy choice. It's a more philosophical topic and less empirical content, but the idea is a very, very simple one. Okay. So my topic is pandemic policy choice in general. It's not about any particular pandemic. It's not about COVID in 2020 or Delta variant or Omicron. But to fix the idea, however, I shall refer to the recent lockdown in Shanghai. All right, but that's only for a matter of illustration. So the dilemma I'll be talking about is: should we adopt the zero COVID policy, or should we rather choose to live with the virus, or to lock down, or not? Well, although I realize that locking down and zero COVID are not necessarily identical. Okay, so Bloomberg reports on the 11th of May that without the lockdown in Shanghai, another city in China, 1.6 million people will die. That's because many of the elderly in China have not yet been vaccinated. And then according to a source from Taiwan, it says that with the lockdown, the economic cost would be $1 trillion. I'm not sure whether it was $1 trillion US or 1 trillion renminbi or what, but in any case, it doesn't really matter. The amount is quite, the amount of economic loss is quite staggering. Okay, let's see. Oh. Okay. I shall set aside various arguments for showing why the zero COVID policy is or is not justified, including the following. Let me just quickly mention three possible arguments. The first one is the view that ought implies can, and that the zero COVID policy should not be pursued if the zero COVID goal is not achievable. That's the first view, but I will not comment on this, just to mention it. The second view is COVID, or rather the Omicron variant, does not do more harm than the flu does. Since we do not have a lockdown because of the flu, we should not have a lockdown because of Omicron. That's another possible argument. And finally, some may argue that a lockdown can save some life, but it can also cause deaths. In particular, a lockdown will cause hospitals and clinics to be closed, as well as surgery to be postponed. Now, this can cause deaths. The loss of life might be comparable to the number of lives a lockdown can save. Now, again, I shall, I just want to mention this just in order to set them aside. The main focus is how should we decide what to do when facing with the dilemma 1.6 million lives versus $1 trillion. How can a bioethicist or moral philosopher address this issue? The short answer is we do not have sufficient information to address it unless we know how the loss of $1 trillion will affect our population. Will the loss of $1 trillion cause serious harm to, say, 50 million people, or only relatively trivial loss to 1.4 billion people? Right. We need more information. Now let me bring in two moral theory. Okay, I want to claim that moral theory can be relevant to resolution of this dilemma. Surely we need empirical data, right? But moral theory is also highly relevant. I shall discuss two moral theories, namely Utilitarianism and Contractualism. Now, I assume that everyone knows a little bit about Utilitarianism, according to which each person is to count for one and no one counts more than one. and then we take account of how different policy options would affect everyone in terms of utility or disutility. So consider the following two options. I mean, the first one is no lockdown, right? The second one is there's a lockdown. If there's no lockdown, we assume that 1.6 million lives will be lost. If there's a lockdown, we assume that $1 trillion will be lost. Okay, let's see. Oh. Sorry, I have some difficulty trying to turn the page. Okay, okay. Now we can translate the loss of 1.6 million lives into disutility. We can also translate the loss of $1 trillion in terms of disutility. Now this book here is perhaps the most important book in telling us how utility can be determined. It's a book called Theory of Games and Economic Behavior by the famous mathematician John Van Neumann and the economist Morgenstern. Well, after we know how the loss of life and loss of money can be translated into disutility, we will then select the option that will promote the greatest amount of collective utility. Without further information as to how $1 trillion would impact the people, we do not quite know how to translate the loss of $1 trillion into utility. I'll return back to this topic, this issue. But one thing that's very, very important about utilitarianism, which I assume is still the dominant ethical theory in bioethics, or the dominant ethical theory that bioethicists would use, is this. According to utilitarianism, it does not matter whether the collective utility is spread out very thinly among 1.4 billion people. For example, China has 1.4 billion people, right? Or whether 50 million people will be spared of some very severe harm, okay? Provided the total amount of disutility or harm to be avoided is the same. So according to utilitarianism, it doesn't matter whether everyone get a little bit of harm, or whether a smaller portion of people get much harm. For utilitarianism, that doesn't matter. However, to illustrate this point, let's consider this. Suppose we can either save a life or else alleviate 1 million people's headache, but not both. Whom should we help? Okay. According to utilitarianism, we should do what maximizes collective utility. Therefore, if the number of people suffering headache is sufficiently numerous, we should alleviate the headaches instead of saving a life. The problem with this implication is that it is incredible, because most of us would believe that we should save a life, no matter how many headaches we can alleviate. So, on this note, I want to look at an alternative theory, namely contractualism. Contractualism says an act or policy is permissible if and only if it is justifiable to every person affected by the act or policy.
Thank you. 2 minutes.
Okay, 2 minutes. Okay, all right. Let's see. So according to contractualism, we should save a life instead of alleviating headache, no matter how many people are suffering headaches. Okay. The rationale is that because a headache is trivial when compared with death, and so we should consider the headache to be irrelevant. Right. So the life always trumps the headaches. However, if the choice is between saving a life and preventing 50 people from blindness, we should prevent the blindness. Now, this is because blindness is relevant even when a life is at stake. In real life, the comparison can be much messier than these two examples would suggest, right? To return to our original dilemma, 1.6 million lives versus $1 trillion, how should we decide? In the abstract, as I said, this dilemma is undecidable unless and until we know how the loss of $1 trillion will impact the population. If the loss of $1 trillion would cause serious injury or harm to 50 million people, say, we should not pursue the zero COVID policy, hence no lockdown. If on the other hand, the loss of $1 trillion would only translate into 1.4 billion people's relatively minor harm, then we should save 1.6 million people instead. Whether we accept utilitarianism or contractualism could affect our pandemic policy choice. A utilitarian could value $1 trillion more instead of saving 1.6 million lives, even if the economic loss will impact 1.4 billion people in a relatively minor way, as long as the total amount of this utility caused by such loss exceeds this utility of 1.6 million deaths. However, a contractualist would disagree. A contractualist would choose $1 trillion instead of saving 1.6 million lives only if this would impact, say, 50 million people rather severely. So yeah, that's it for my talk. I've discussed the difference and the rivalry between utilitarianism and contractualism much more detailedly in this paper. Okay, so thank you.
Thank you very much for that. That was very helpful to have a different perspective on the issues. So now for our final talk, we have Sarah Devani, who is Senior Lecturer at the Centre for Social Ethics in Manchester, and will be giving us a legal perspective on the issues. So thank you, Sarah.
Thanks very much. Can you see my screen all right and hear me okay? Okay, thanks very much for organising the webinar. In this brief presentation, I'm going to discuss what might constitute an appropriate approach to regulating public health at an international level, what that might involve, and the effect that this should have on national approaches, filtering down to those as we hopefully eventually move from the pandemic to the endemic stage of COVID-19. And it's this transition from pandemic to endemic that's the focus of the World Health Organization's March 2022 strategy, which is looking at ending this acute phase of the pandemic. And it's critical now, contemplating that move, to develop an approach to regulation that incorporates all we've learned about regulating public health effectively in the face of a disease like this, as well as, really importantly, populating that with appropriate ethical values. So I'm going to explore whether a principles-based regulation approach can fit that brief, and I'm acutely aware that I'm discussing a principles-based regulation approach from a jurisdiction that isn't at the moment particularly defined by its principled approach, but nevertheless we need to strive for that approach. Now, it's important to bear in mind when we're thinking about the appropriate approach to regulation that much is in a state of flux at the moment. So firstly, in relation to the disease itself, and secondly, in relation to global regulation. So in relation to the disease, are we really heading towards the endemic stage? That's what the WHO is planning for. The US Centre for Disease Control and Prevention describes the endemic stage of a disease as the constant presence or usual prevalence of a disease or infectious agent in a population within a geographic area. And that constancy is not quite in play yet at the moment. There are still some really fundamental uncertainties that remain in relation to variant transmission and variant impact in relation to the various Omicron variants. And also we need to be acutely aware of new and emerging diseases and or variants of COVID. So lots of flux as opposed to steadiness there. In relation to global regulation of the pandemic, at a global level, international cooperation is coordinated and overseen by the World Health Organization. Article 1 of its constitution sets out the WHO's aim of the attainment by all peoples of the highest possible level of health. That's its fundamental aim. And health is defined as a state of complete physical, mental and social well-being, not merely the absence of disease or infirmity. So the central importance of the WHO to the international response to the pandemic has recently been reflected in a commitment by its member states to increase their funding contributions to it. But in turn, WHO governance reforms have been required in relation to transparency, accountability and efficiency. So there's some movement there in the WHO's own governance. We're also in a state where we're both having to be ready for other emergencies emerging, as well as having appropriate governance in place for the transition to the endemic state. So there are two different types of approaches that are needed there. And so this is characterised by a move from emergency measures to longer term provisions to try and manage risk. Another area of regulatory flux at the moment is in relation to the international health regulations, which are the legally binding international treaty agreed on by the member states to the World Health Organization, which aims to help prevent and respond to acute public health risks. So that's been the one that's been in play throughout COVID. This year, a working group within the World Health Assembly, which is the governing body of the WHO, has recommended targeted amendments to that fundamental treaty. So lots is under a state of flux and change at the moment. The World Health Organization's strategy aims to enable, as I mentioned, the world to move from this acute phase of the pandemic out of that, but it does recognise itself that there are a number of challenges to regulating that move. So we're still dealing with unpredictable immunological and virological drivers of transmission of COVID and its impact. And this also importantly needs to take into account national capabilities of responding to transmission and impact. So whether that's in relation to vaccine programs, levels of immunity within the population and diagnosis and treatment resources. And the WHO also acknowledges that its strategy needs to cope with dynamic changes in context, and those national contexts, as I've mentioned, are very different. So it recognises that it needs a multi-layered and agile regulatory approach that balances preparedness for emergencies with risk toleration and steadiness in public health. So a lot of competing factors there. So what regulatory approach can be effective in the face of these challenges while still facilitating the WHO's aim of the attainment by all peoples of the highest possible level of health? Well, if we look at traditional rules-based regulation, that certainly has advantages as a regulatory approach. So it can provide certainty, clarity of standards and consistency of application. But in a fast-moving and changing situation that can be unpredictable, it has significant disadvantages. Where the context change, the parameters of the rules can find that they don't incorporate those changes. So gaps gaps can appear in regulatory coverage. There can be inconsistencies in approach depending on how factual circumstances play out, and it's often found in fast-moving areas such as science and technology that rules-based approaches are difficult to future-proof and become inconsistent and inapplicable over time. So this leads to challenges to the credibility and legitimacy of the regulatory system. So I suggest that there are technical and ethical imperatives for a principles-based regulatory approach in the COVID context. A principles-based approach uses high-level and broadly stated principles to govern a fast-moving, unpredictable area. So it puts in place overarching requirements that can then be interpreted to fit the context. So this can lead to it being flexible and agile and responsive, as opposed to fixed and unwieldy and inapplicable. Its broad application can mean that it can apply to a wide range of contexts, and importantly, it places at its centre a particular aim or aims that become the focus of the interpretation of the overarching principles. So the spirit of the regulation, guided by these principles, stays at the centre. It can reduce complexity and proliferation of very detailed provisions. And this can fit in with an avoidance of duplication and overlap and fragmentation that the World Health Assembly is saying this year in its annual meeting that needs to be avoided in regulation going forward. So it can work in context with, thank you, it can work in context with rules beyond which we don't want anything to go, but it allows for that flexibility within that context. So it's arguably better at responding to situations of change. Now, principles can pervade all levels of regulation and multiple regulatory actors, so they can apply at international levels and filter down to populate national and local approaches. So it can affect all kinds of actors that are involved in the pandemic, moving to endemic response, from scientific researchers, perhaps using principles to get them to share their knowledge, through to regulators, interpreting actions in light of the principles, inform public understanding, and healthcare practitioners' responses to resource and treatment decisions. But what principles should apply? We've heard today that there are a variety of principles that could apply, and the WHO has stated that equity and solidarity must be our watchwords. The principle of equity lies at the heart of its recommendations that the international health regulations be amended, and they want that to pervade this fundamental treaty going forward. Bearing in mind the focus on the aim of the attainment by all peoples of the highest possible level of health, choosing carefully the principles, the ethical principles that should guide public health regulation is really fundamental, and will provide a constant reference point for us to assess whether steps being taken will help achieve that aim. But it's imperative that national regulators now embed principles in their public health regulation, which will avoid the so-called immoral race to the abyss that we saw, for example, accompanied vaccine procurement in 2021. And it's really important that there are discussions at international level about what principles should be used now to govern both pandemic preparedness and endemic regulation going forward. Thank you. Oh, you're on mute, Lucy.
Sorry. Thank you very much, and thank you to all our speakers for those absolutely fascinating talks. Sorry, apologies. I think I'd have had to hang a bit by now. So I'd like to open it up for questions. So please, if you're a participant, put a question in the chat, or you can always, if you want to speak, raise your hand, and I can you can ask your question. So while people are having a think, if I'll use Chair's privilege to just ask a first question to all the speakers, and that is, do you think we can have a set of principles that can be applied internationally? So who would like to tackle that?
Well, I think the simple answer is yes, we can have a set of principles that are internationally agreed. But if something like COVID-19 happens again, they won't be applied. The sort of the pressure on national political decision makers to take their national interests into account will mean that they won't be applied. That's my sort of cynical view.
Okay. So lip service might be paid to them, but in practice, people will.
Well, they'll probably be applied in slightly less critical situations, so they're not worthless. But I think the idea that national decision makers would stick to a set of principles if it was strongly against their national interest is, well, I don't think it's realistic.
Okay, would anyone else like to comment on that? And then we'll have a question from Alexis Payton. Roger?
Yeah, I'm just going to take a quick stab at it. I think we have to make an argument that the scope of justice can be applied globally, right? So, because a lot of people will be saying, well, you know, the principle of justice could be different in this country versus that country. So why does it have to, why the scope of justice has to apply to global health, for example, right? So we need to make arguments that, you know, if we're, for example, if we're talking about Rawlsian justice, we have to make an argument that the world right now, as of now, fulfills that criteria as proposed by Rawls. For example, you know, this is just one example, and this is what we're in agreement now. I think the world, you know, I agree with Professor Holm, you know, that it may not be realistic, but if we can make that argument that this really concerns everyone, not only, you know, on a national level, but we have to really deal with it on an international level, then maybe there's a chance.
Okay, thank you. Does anyone else want to comment on that?
I think we are seeing a move towards internationally agreed principles being certainly put in place. So there they are, equity and solidarity at the centre of the World Health Organization's approach. I think, yes, certainly if we're realistic and we learn from what's happened in the COVID-19 pandemic, we saw national governments acting against their own national interest by seeing themselves, even if they aren't geographically an island, as an island, and not recognising that, you know, ease of transmission and so on, and that, you know, where one country is affected, others will soon follow. Trying to be a bit more optimistic, and I do accept that national governments obviously have a duty to their own population. I think there is some optimism there, given that this is now being placed at the centre of international requirements, the major treaty, that despite you know, human nature and national governments acting in self-interest, this sort of pervading of principles will filter down and will improve future responses, hopefully.
Okay, thank you for that. Do you have a question, Alexis, you'd like to ask?
Oh, yes, sorry, just unmuting there. Thank you. These have been really great talks. I think, actually, Lucy, I kind of wanted to push our speakers a bit further on the question that you asked. So when we look at a lot of the principles that have been used in the past 2 years, there seems to be quite a lot of agreement, and they are different versions of what Sarah was just talking about. But one of the things that seems to be coming up a lot when we talk to the groups that we're asking to apply these principles is the actual application of it. And I wonder if that's perhaps where we should be concentrating our international efforts, is to help guide application of what are, I think we can all agree, nuanced, sometimes vague, and also a bit generic principles. So I wanted to ask the panel what they thought, how we make that jump, that next step. So we all seem to be talking about relatively same principles here. How do we make that practical for the groups that we're asking to use them?
Who'd like to speak to that?
Just very quickly, it's a really good question, and it's a feature of principles-based regulation, that one of the things that you need is to have you know, a very well-informed regulator who understands the context, or advisory body that understands the context, but also understands the challenges that lie in interpreting and applying those principles, whether you're a healthcare provider or a policy maker and so on. So it might mean, for example, that the World Health Organization has to be really on it in terms of what it means by equity, and it looks as though it's going to be undertaking more work to interpret that and consider those the application of that principle in the amendments to the international health regulations.
Okay, thank you. I'll just come to 2 points made by Jean Wu in the question and answer. So Jean says, pandemic policies are made by politicians. Should one argue that politicians be guided by these principles? And if so, is this ever possible? And do politicians understand what the ethical considerations are? It's probably a short answer to that. Is there a longer reflection? Do you think politicians? Sorry.
Yeah, I think the first answer to the first question is yes. At least politicians should be guided by the principles they have committed themselves to. And most sort of politicians, at least in countries where you have party systems, do commit themselves to principles which are at least vaguely ethical. Now, whether they understand the principles they have committed themselves to, I think is a completely different question, and my guess is that most of them don't, or haven't, or perhaps more accurately, haven't really thought about what these principles actually entail.
Okay. Anyone else want to comment on that?
Yeah, can I say something?
Yes, please.
Yeah, I agree with Storm's view that I mean, at least in practice, country will behave in such a way that they take their national interest into account much more than any impartial principle of fairness. I'm saying this because even in ethics, in Western ethics, not only do we have impartial ethics, we also have the idea of the so-called agent-relative reasons. Let me give one example. I mean, if there's one person, if either I can say one person or 5 people, I should say 5 people, right? But if this person happens to be my mother, who should I save? Of course, I should save my mother. I think many people will say that if it's my mother versus 50 or 500 people, it's permissible for me to save my mother. I mean, this is the so-called agent-relative reason. And this is not supposed to be selfishness. It's supposed to be perfectly justified ethical grounds. And if that's the case, then, you know, if it happens to be my country, you know, my countrymen or people from my nation, I should place, how should I say, more weight. I mean, for me, they have more weight than people from. So I think even on the level of principles, there will be a lot of discussion, and not to mention in practice.
Yes.
Thank you.
That's the point about who is our main focus of moral concern here. And I think Roger's talk really illustrated how do we balance the economic versus the health concerns and also the interlinkage of those two. So I think we've got time for one last question. Oh, right. Sorry, one last question. From Ming Fen, would you like to ask your question? No? Okay, I think Alexis said Roger wanted to come in there. Was that right, Roger?
Oh, no. I'm just helping out to press the answer live button.
Okay.
But yes, I just one last quick answer to that. Yeah, it would be lovely if politicians are guided by ethical principles, wouldn't it be?
Okay, well, I think we can't, I think that's a great conclusion to this session. So, well, thank you very much. I'd just like to thank all our speakers for what, although it was very short, was an extremely fascinating session. And I'll put together a sort of edited slide deck of the talks, if that's all right with the speakers, and share with the participants. So if you could join me in thanking our speakers, and hopefully this will be the start of any other future collaborations. So thank you, everybody, and thank you, everyone, also for joining us, and I hope you found it interesting. Okay, very much.